is 12:05. We might have some more folks call in as we get started, but for the sake of time and all of your all's time, we'll go ahead. This is our first time doing a virtual meeting for our general chamber meeting. Our last one was in March, so I appreciate you all calling in and being a part of it. We're not going to go through our typical chamber business. It's going to be too hard to try to make motions and seconds and do all that typical business. We will continue doing that when we meet again in person, which we hope to do sometime this fall. We're going to kind of reevaluate how things are looking locally in August and then look at maybe meeting in person then or in September. And so today I'm going to introduce our speaker, and we'll hand it over to her as she kind of talks about her role in the region and the work she's doing. I'm going to read a bio that she provided to give you all a better introduction. Dr. Margaret Riggs serves as a captain in the U.S. Public Health Service and is the Healthy Communities Director and CDC Liaison with Shaping Our Appalachian Region, where she leads coordination for health improvement in Appalachia, Kentucky by preventing substance use, diabetes, and obesity. Currently, she is providing leadership and technical assistance during the COVID-19 pandemic in Appalachia, Kentucky, and the northeastern U.S., from New York to Virginia in the mid-Atlantic region. In May, she deployed to assist the Navajo Nation. Dr. Riggs has been working in domestic and international public health for 15 years. Most recently, she was an associate director at CDC Zambia, working with the U.S. President's Emergency Plan for AIDS Relief, focused on establishment of the Zambia National Public Health Institute. Dr. Riggs also oversaw 3 branches with 25 staff: Field Epidemiology Training Program, Health Informatics, Epidemiology and Science with the HIV/AIDS Program. Prior to joining the CDC Zambia office in 2015, Dr. Riggs was with CDC Atlanta as a supervisory epidemiologist in the Career Epidemiology Field Officer Program. She oversaw 30 senior epidemiologists assigned to state and local health departments around the U.S. and its territories who work to build public health preparedness and outbreak response capacity. She also served as acting territorial epidemiologist for the U.S. Virgin Islands and participated in several large public health response efforts to include Ebola virus disease in West Africa, Superstorm Sandy in New Jersey, and the Haiti earthquake. Before moving to Atlanta in 2012, she was a CDC epidemiologist with the CEFO program assigned to the Kentucky Department of Public Health in Frankfort. In this role, she worked across Kentucky responding to natural disasters and outbreaks, building environmental health capacity, and helping to improve overall health by getting Kentucky kids outdoors through relationships between local health staff and environmental educators. Dr. Riggs began her career with CDC in 2005 as an Epidemic Intelligence Service Officer at the National Institute for Occupational Safety and Health in Cincinnati, Ohio. She graduated with all degrees from the University of Florida, served 5 years in the U.S. Army, and grew up in northern Kentucky. I don't know if we've ever had a speaker so qualified to talk about the topic we've asked them to, so we're really appreciative to have you here. And I guess I'll ask all of you all to make a wave at the camera to give a warm welcome to our speaker today, Dr. Margaret Riggs.
Thank you very much, Colby. I'm happy to have a chance to talk with y'all. As he mentioned, I'm with SOAR, and so I help kind of direct the Healthy Communities program that we have within SOAR and interact very closely with all the other blueprint goals. When I came, mostly was focused on substance use and diabetes, but as we know, COVID hit, and so since the pandemic began, I've been focused mostly on COVID response and prevention. And more recently took on the role, in addition to supporting our area, to working with basically the Northeast and the Mid-Atlantic and trying to help from a broader perspective. So I thought I would just get started with talking a little bit about where we are now. I was looking at the numbers specifically for Harlan. I've been watching Appalachia in particular. I know Kentucky, on their website, their COVID site, puts up information across the state and has it by county. But I've been putting together the information for our 54 counties that make up Appalachia. Harlan, as you know, we didn't see cases coming there until, almost Memorial Day, actually. I think being kind of tucked away in the mountains helped a bit. You're not on the main interstate arteries, not a lot of transit coming through. So that kind of protected us over here in the mountains a little bit. But then I look at, from Memorial Day till the week of June 9th, we had 8 cases. The week of June 26th, we have 18. And now, as of yesterday, we've doubled that 18 nearly. So we're at 32 cases now, was what's reported on the state's website. And sometimes there's a little delay with what's happening locally and what's reported through the state. But nonetheless, there are 2 deaths, 2 folks lost to this disease in Harlan County. And as I just reported up to our board yesterday about what's going on in Appalachia, specifically in the past 2 weeks, we've seen a 35% increase in positive COVID cases. Now, some of this is due to we're testing more, we have more availability now. It's also opening up, right? We're allowing folks out and interacting more, and so that's going to happen. The good news with that is most of those folks can recover at home. And we're not seeing a big leap in the number of hospitalizations. We're not seeing a lot of folks admitted to the ICU. So if it is those younger folks, maybe a little bit healthier folks that are getting infected and can recover at home without needing that critical care from the hospital, we're doing okay. What we don't want to have happen, though, is to let our guard down and create a situation where we have such an increase in cases that we're now risking exposure to those who are at highest risk. And, that really hasn't changed since the start. It's, those who are older, kind of, they stick at the age of 65 to kind of say you're more high risk. But really, it boils down to your health. And as we know in Appalachia, and the whole reason that I was assigned here by CDC to work with SOAR is because of our poor health indicators. Obesity alone is a high risk factor for having a bad outcome from a COVID infection. This is really a vascular disease when it comes down to it for the bad outcomes. We know it's transmitted through respiratory. I mean, we start showing respiratory symptoms maybe as our initial indication that we have this disease. But the really bad outcomes are for those who have more of a vascular challenge or an immune system challenge. And diabetes is right up there at the top of the list, kidney disease, any cardiovascular disease, lung disease. So we really tried to get messaging out and worked hard across this region, all the health departments, messaging and advocacy groups trying to get word out to the coal miners, former miners, their families, as well as to all of our different health groups, the diabetes coalitions, and doing what we can to get the word out about the seriousness of this disease. And so unfortunately, it's not going away anytime soon. And I'm looking again, like the proportion, I've been looking at the proportion of cases in Kentucky that come out of Appalachia. That's one thing I wanted to pay attention to. I think we make up like 25% of the population of Kentucky, if you look at all 54 counties. And right now we've increased our proportion that we're finding positive as a part of Kentucky as a whole. So last week we made up about 10% of the positive cases. 2 weeks later, we're making up 12%. And we don't want to see that number continuing to spike, because then that's going to mean it's hitting us harder over here. And one of the concerning things I looked at overall in Kentucky from 2 weeks ago, there was an 11% increase in deaths. But in Appalachia, we had a 19% increase. So we are ahead of what the state average is for the increase in fatalities. Now, most of these were at long-term care facilities. and that's true across the state. But that's why it's so important to protect those who are at highest risk. I know we're all tired of it. I've been living this, doing this pretty much 24/7 for, since February, March, and I'm really tired of it. But the bottom line is it's still here with us. It's going to be here with us, and we have to take it seriously. Some of the things we can do, are pretty simple in the grand scheme of things. We keep learning more about this virus as time moves on. We may, as CDC, update guidance based on new things we learn or information that really solidifies something that we were presuming to be true. And one of those things is wearing face coverings. It's such a simple thing to do, and it really can stop the spread. It really can protect lives. I noticed even West Virginia's governor, as of yesterday at noon, masks are mandatory in the state. Now, it may be a challenge to enforce it. All along Kentucky, our governor, our leaders, I guess when it comes down from higher leadership as a requirement, that may make folks take it a little more seriously. It's difficult to enforce. No one wants to try to enforce that, but we just want folks to do the right thing. And if this simple thing can help save lives, it's worth doing. And, particularly from a business perspective, this is something, your employees who are indoors, close to customers, it's something they can do. The mask is more the one wearing it. It doesn't provide 100% safety for the person wearing it, but it does reduce your risk if you're wearing it. Since this virus, we know how it spreads. It spreads in droplets that come from our mouth and nose. We're always expelling water droplets. You've seen, I'm sure, those videos that show, the black background and the spray coming out when someone sneezes, coughs. Also, it's just from talking. We've learned and we have evidence showing that, particularly in indoor spaces where someone is singing or where you're talking really loudly, we've seen it spread quite rapidly. And, those two scenarios work out to be, kind of churches where we've had the chorus, the choir coming together, singing. They've seen spread that way. And we've seen it in the bars. Myrtle Beach is getting hit really hard and has contributed to spreading it around our region, actually, and in Kentucky, because of people more than likely in a bar. You let your guard down when you're having a few drinks, and you're also talking really loud because it's loud in there with the music. And so that really is creating a challenge for us here as folks go out on vacation and go to hot spots. Florida's getting hit really hard. Texas, Arizona, the Sun Belt states are all seeing things kind of spiral out of control. Because of that, CDC has started sending in what they're calling CRAFT teams. So that's COVID response assistance field teams. So they have teams of feds that have come out to at least a dozen cities so far, in the South mostly, but also even into Cincinnati and some areas north. And they're really working on interventions and mitigation measures and helping those areas think through how they can approach it a little bit differently to protect their communities. So maybe I'll stop there, and I'd love to hear any questions from you all or things that I could help you answer. I really wanted this to be more about, how can I direct any guidance or look into something further that would really be specific for your needs. Hopefully you all could hear me.
Yes, I was having trouble coming off mute there.
Okay.
I do appreciate all the things you had to say. One thing I would like you to share, and if anyone else has questions, feel free to take yourself off mute and ask a question. Is there a good resource of guidance we could be providing to our local businesses, something published by the CDC, to help them find ways to slow the spread for their employees or their customers coming into their places of business?
Yes, definitely. So we have a lot of guidance out there, and I'll try to share my screen now. Hopefully, I know it's challenging for those who phoned in, but if I can share my screen. Let's see. Okay, I thought I had all this pulled up, but apparently not. There we go. So I'll share this first. I mean, this is cdc.gov/COVID-19. You can find all of this. Often it's easier, and I do this myself. I just put in whatever I'm looking for. You know, it might be workplace guidance, wearing a mask, whatever it is, with the word CDC. I just Google it. We don't have the best search engine within our CDC site. So sometimes it's easier just to put the thing you want and put CDC in there and you can find it. But, you know, we have from the basics of like how it spreads, some of the things I was talking about person to person, it spreads very easily. You know, we're not seeing this thing go away with the summertime. One thing good about summertime, we can be outdoors more. That's the key. Staying away from each other, really taking that 6-foot distance seriously. There's a lot of things we can do. And then there's workplace. So this is specifically for healthcare workers, but you know, I thought it was something important to share. You know, workplace return to work criteria. So they even have specific guidance on what to do to allow our healthcare workers to return to work if they were positive, if they were confirmed or suspected. This is a big question in everybody's mind. How do I know when it's safe for my employees to come back to work if they're positive? And then, you know, there's guidance here, how to wear, we have everything on how to make a face covering, how to wear them properly. One of the things I've seen is that people are wearing them, but where's my mask here? This is my favorite way to see people wearing their mask. You can see me chin wearing. It might do really well to keep your beard hair from falling onto somebody or something. It doesn't stop your germs from coming out of your mouth. Even this, covering your mouth only. You still have your nose open. So one of my favorite memes I saw was treat your mask like you would your underwear. Put it on before you go out in public. Don't fiddle with it when you're in public. And definitely don't let parts hang out of it. Cover all the appropriate parts with your mask. So, you know, again, it's a simple thing we can do. It's uncomfortable. It's hot. I know it is. I don't like wearing masks either. And initially, when the guidance was not telling us to wear masks, you know, those of us in public health and science, we're thinking, you know, no, we wouldn't want to wear a mask because it's not going to protect me. We think about a mask protecting us, you know, the wearer. And it wasn't something that was in our toolkit to use to protect the wearer. You have to have fit testing and wear a specific mask. That's for healthcare workers or industry. But as we learned more, we found that this simple cloth will stop you from spraying germs on other people. And that's a big way to reduce the spread. But yeah, CDC has specific guidance. Like this is, I'm showing the reopening plan. It has really, you know, kind of step-by-step guidance for when to test and when we can, the gating indicators for when we move from phase to phase. And it, you know, states and jurisdictions should meet certain criteria to be able to do that. And, you know, I can show you also, you know, potential exposure at work. There's all sorts of work guidance. This is again in the healthcare workers, but I'll go in the section, I'm kind of scrolling around the top, but businesses and workplaces. There's a lot of guidance here. The latest update was July 3rd. So we keep updating, we keep listening to, and folks like me, we have many CDC who work out at state and local jurisdictions. So we give them ground truth. You know, we try to say, hey, here's what my community needs. I'm serving as a liaison right now. So I'm learning, you know, questions coming from Delaware, from Pennsylvania, from New York, from the islands, like all over. And I'm trying to help, you know, inform them with things I've learned by working with health departments here in Eastern Kentucky. And likewise, I can then share and say, hey, you know, this area is getting hit pretty hard. Hey, pay attention to this, you know, to my health department directors here so they can get ahead of the game a bit. You know, they have everything about like how to set up testing if it's a larger workplace and they want to set up testing for their workers. You know, we don't have them so much over here, but like meat and poultry processing, that's been a big problem all across the country. And think about it. What's that workplace like? They're indoors, they're in close quarters, and guess what? They need to wear hearing protection. They can't hear well, so they're yelling. The louder you have to talk, the more you're likely to spray germs. And then in those scenarios, we have a lot of folks, you know, migrant workers, new Americans, they're the ones working in these places and they live in very crowded conditions at home. I was out on Navajo Nation. I was surprised. They are very much like Eastern Kentucky more than I realized. They are coal miners out there, rural community. They're, you know, very family oriented. They have multiple generations living together at home. They have some of the bad side of things like we do, the poor health indicators. They have high diabetes like we do over here. They have the drug situation is bad there, a lot of substance use disorder and, you know, untimely deaths of families that really cause grandparents or other family members taking care of those younger ones. And, you know, they got hit hard because Arizona, you know, unlike Kentucky, Arizona didn't do a lot of those steps to shut things down early. We did. Kentucky, we shut things down even like before New York, I think. We started shutting down, you know, March 13th, and New York was still telling people to go out and do their normal business. Well, we see what happened to New York. Huge spike. They did not flatten the curve. They were the example of what not to do. But now they've gotten it under control. They did take measures. They did slowly open, and they're still very, very stable because of that. We see those states, Arizona, Texas, Florida, they opened really quick. And, you know, as I was using example here, it was tough, it was painful, but it was a lot easier to flip that light switch off and shut things down. And everybody had a little more fear and wasn't sure what to do. It was easier to flip the switch off and stop everything from being open. What we really need to do is, you know, we're seeing it in Kentucky. It's more like a dimmer switch. You know, Florida, Texas, they flipped that light switch right back on. Arizona, they opened things up and just said, okay, let the horse out of the barn, take off running. It's got to be the dimmer switch. Dim it up a little bit, dial it back if we need to, if something starts to get out of control. But we got to get businesses open. We got to get people back to work. We got to get kids to school. CDC is working. The White House is working on updated guidance to really give a little more specifics. I know schools are putting out plans they have for reopening, and they're presenting them and working with their local health departments and with the state, Kentucky Department of Education. But we at CDC and the White House Task Force still working on more specific guidance to give them. You know, as school districts start writing plans, more questions come up. So we're trying to help from a national level and learning from all across the country and learning from international. You know, international schools in many countries have already opened. So what can we learn from them who have already gone through this and employ some of the best practices? But I'm happy to take any questions. Maybe some of you, I hope, were on the call we did with SOAR. I think that was back in maybe April. I did do a SOAR call where a webinar where people could call in, and I focus specifically on businesses and workplaces. But please, what questions do you have?
Yeah, any other questions in the audience? Feel free to come off mute and ask a question.
And I'm happy to try to answer any of your COVID workplace questions.
I'll ask one more question if no one else will. When should someone get tested? Should you wait until you're showing a symptom? Should it be based on if you travel somewhere? We have some clinics set up this week in Harlan County that are offering kind of drive-through testing or testing for anyone. And so when should we decide if that's the right thing that we should do?
Yeah, testing is so available in Kentucky, and we are very lucky. Other states are not having that kind of availability. I think we're seeing, in Arizona, there's long lines of cars waiting to get tested. We have, I think, aside from Hawaii, which they're pretty isolated and remote, we have the quickest turnaround time for test results of any state in the country. And DC and can't remember who else is pretty low on there, but it's taken them 4 and 5 days still to get test results, or even up to 8 days. We can get a test in 24, 48 hours here in Kentucky. We've got plenty available. We got more tests than we have people willing to go do it. So I would say, you don't wait until you have symptoms. If you've been on vacation, like many of us have, I mean, I right before Florida went up in cases, I went down. I was in the Panhandle area with a couple of my cousins were there, so I went and stayed down there with them. I got tested when I came back, although I was as careful as I could be. You just never know. For instance, in their condo, the elevator, some strangers got on. I didn't know. I got right back off the elevator. There's no way I'm going to be in an enclosed space, and none of them were wearing a mask. So you just never know. We were safe. We kept distance. We wore masks when we had to go out to the store and that sort of thing. But, I got tested when I came back. What we know about the virus is that it can be spread before you have symptoms. When we see people start to show symptoms, we're finding that they are contagious and spreading it even up to 2 days before they start showing symptoms. So they're pre-symptomatic. You hear a lot about the asymptomatics. There are some of the symptoms are mild, particularly in kids. We have kids that are spreading it, and the kids just have a runny nose. They may just have some very mild respiratory symptoms, and most of them do just fine, recover. You wouldn't even know that they had this virus. But waiting for symptoms isn't always the best. If you think you were exposed, if you've been out in public, if you've been out to another area, we have plenty of testing. Go get tested. It's a little uncomfortable. It's not really painful. I mean, the swab, it's 2 centimeters into your nose. Sometimes in the hospital, they'll do the one that goes a little further back, and that one does it's annoying. It doesn't hurt. It's not like getting an injection or anything like that. But it's pretty simple, and it really helps us keep an eye on how things are going from a national perspective and local perspective in public health and the state. And that's how we make decisions about whether to move into different phases. I had that situation with Delaware. I'm advising them. They did a testing blitz. They had testing out at the beach, Rehoboth Beach. They set up testing sites, found a bunch of positives, and they didn't move into phase 3. They were supposed to move into phase 3 right before July 4th, like Kentucky. They did not move. And, their governor came out and said, most people are wearing masks. Most people are doing what they should. But until everybody is really taking this seriously and doing it, we're not moving to phase 3 and going to mandatory mask wear. I think that's what happened in West Virginia. The governor threatened it. He said, you don't do what you're supposed to do, I'm going to make you wear a mask. Okay, now he made him wear a mask. So I hope we don't get to that stage here where we're trying to force people to do it. Just do the right thing. go get tested, you know. Yes. Somebody had a question?
I have a question. I hope I'm off mute.
Yes.
Okay, so as far as false negatives or false positives, I know that you can have a false negative if a person is tested too early in that window from the time they were exposed. But what about false positives? Are you seeing a lot of those?
Yeah, that's true with any test. What we often do for any kind of screening is we want to cast a wide net. We want to make sure that we catch positives. So we may have more false positives because of, having that test be so sensitive. And there really aren't too many aren't too many bad things, I should say, that go along with a false positive. Because with other diseases, if you have a false positive, it means you start a treatment, right?
Right.
There's no treatment we're starting people on. So it's pretty safe, even if we do have some false positives, because we know we're keeping a wide enough net that we're definitely catching all the real positives. So there always is that chance with any type of screening test. But this one, there's different manufacturers out there. There's differences about how the sample was collected. We found that a lot of times when a particular manufacturer or brand was found to show a lot of false positives, it was because the ones collecting the test weren't doing it right. Using the right media, or maybe the sample didn't need to go into a preservative media and they did it, and that messed up the test results. There's some of that operator error that might happen as well. But what we do know is that this test is, it's not infallible, but it's a pretty good accuracy of what's going on in the community.
Well, good.
Yeah, and there's a little more challenge with everybody's wanting the antibody, the serology. That one is not quite there yet. It takes time to develop these tests, and everybody rushed to get the serology tests out there. We know that the molecular test, the one where you're doing the swab and seeing if you're positive, that one's pretty accurate. The antibody test, not so much yet. And also, we just don't know enough about this virus, even still, to know when you're going to mount an immune response. I'm on CDC calls every day and hearing about all of the research they're doing and the surveys that are going on to learn more about, when do you mount an immune response? We don't have that answer yet. We think it might just be a few months that you might have immunity. There's the possibility you could get this again. We all know how we get cold viruses over and over. You can get the flu virus again. This virus is a coronavirus, similar to cold viruses, but it's very different, and it is very different from the flu. But yeah, I've had the test now 4 times. I was out at Navajo. I got tested. I participated in one of those first drive-through clinics, the one in Pike County. I did it when I came back from Florida. I had to do it with CDC as well. So I feel pretty confident in saying these measures we're asking people to do work, because I've been in hot zones. I was there on Navajo Nation, right? If you heard the news, that was in May. They were spiking. I was in a hot zone. They had an outbreak of workers in their hospital that we were working with and assisting. I kept distance, washed my hands, I wore my mask. I did the thing, I practiced what I preached, and so far, knock on wood, I have been free from the virus by doing these basic things that we're recommending.
I wish the masks were mandatory in Kentucky, because I feel like there's so many people that aren't wearing the mask. It's very concerning.
Yeah, I know. I agree with you. I wish people would do it, and I understand from like the political side or the leadership side, it's hard to enforce. Why would you mandate something you can't enforce? And, I guess West Virginia, they decided to do it, make it mandatory. I guess it's more of a statement and the leader, putting that kind of pressure on folks. And, unfortunately, we're still going to have folks who don't do it, even if it does become mandatory. But workplaces, you have a little more authority to tell people they have to that work there, and, getting your customers to wear it. Folks come up with sorts of reasons why they can't wear a mask. A lot of that's really just not valid. I mean.
Yeah, I agree.
Yeah. I mean, it's different if you're wearing an N95 or, anybody working in industry. If you're wearing a full face respirator or half face respirator, yeah, that seals to your face and really restricts breathing. And that's why you have to be fit tested to wear it. But cloth face coverings, just something to help stop your spit from coming out. It doesn't have to seal your face. It's really just stopping the drops from coming out. So, I really hope I'll kind of plead, I guess, with you all as leaders there in Harlan, set the example, try to lead and message to your employees and customers and your community. This isn't something political, really. It's not. And I know the media and lots of social media has made it that way. This virus is real. It's around the world. It's impacting everybody on this planet. And I've heard people say, the mountains and our hollers over here protect us. But just like, they protect us from a tornado too, right? We don't see tornadoes here too often because they kind of bump over or run into the mountains and they don't come in. But once they get in, they do a lot of damage. When that tornado hit in West Liberty and came through, I was in that response in 2012. It did a lot of damage in the mountains, and the virus is going to be like that. I think, we can keep it out, but if it comes in, it's going to do a lot of harm because of our high risk folks. And I've heard a doctor in Pike County, he's been saying, the virus, we kept it out, but we weren't happy about that. So now we've gone out to go get it and bring it back into us. It's not coming in on its own. We're bringing it back in.
So how long do you think that we're going to be dealing with this virus? Till we get a vaccine, and then how long do you think that will take?
Yeah, I know. So the White House team and Dr. Fauci from NIH, they're talking about around the first of the year, possibly. They've really ramped up creating this vaccine quicker than anything we've ever seen to try to get a vaccine. Challenge will be is how effective is that vaccine? They may have one. How long is it going to provide immunity? For viruses such as this one that mutate quickly, we have to get revaccinated frequently. It's not like, you get your polio vaccine and you're good. This one, viruses mutate, we have to get frequent revaccinations. So even if it comes out, it's not going to be like a big savior that makes this all go away right away. And how long will this be around? Gosh, I wish if I knew that I could be very, very wealthy, I guess. But
right.
Yeah.
I know nobody knows.
Yeah.
I was just curious what your theory was.
Yeah. Unfortunately, what history has shown us, not just from 100 years ago with that other pandemic that was an influenza pandemic, but also in the 60s, there was another pandemic. And what we've seen historically is springtime it hits, and then it comes back harder in the fall. Don't know if this one will. We hope that the mitigation measures that we put in place, those drastic measures of shutting everything down, protecting our most vulnerable, and now slowly opening, we hope we'll get some of that herd immunity, what you've heard people talking about herd immunity. if we get to a point where 70% of the population has had the virus and mounts an immune response, or they're vaccinated and have an appropriate immunity, then it's less likely to reach those high-risk folks. But there are dangers to reaching that herd immunity naturally, because not everyone that is infected naturally by being exposed in the community will do well. We lose folks to this kind of natural experiment in herd immunity. And that's why the emphasis to try to take care of our high risk in particular. But will we have mounted enough of an immune response by the fall when we start to be more indoors and spreading things? We know we spread things more in the winter. That's why we start seeing all the stomach viruses come up and flu and cold viruses. You know, we're indoors more and we're sharing things more and touching things and sneezing and coughing more close to each other. So our predictions are showing that we're probably going to see a second wave. We're going to see COVID mixed in with flu and cold viruses. That's why I think it's even more important to get tested, because we won't know what it is. And, you know, kids, they go around with runny noses all the time, you know, and pick things up. Is it just a cold virus that we'll see the kids have, or is it COVID? Because if it's COVID, then that puts grandparents at really much higher risk, or anyone in their family that, you know, is obese, has diabetes, has heart disease, lung disease. So we really will need to continue getting folks out there to get tested. What I've seen too is that people don't recognize some of the symptoms they have. They think, oh, it's just allergies. You know, I helped some of the Kentucky River District, I was helping them do the contact tracing, and some of the people who came up positive said, oh, I thought it was just allergies. Oh, I thought I just had my sinuses, you know, acting up. You know, headache, congestion, loss of taste and smell, these very mild things that we may get on any given day because, you know, maybe you didn't drink enough water, you get a headache, or, you know, pollen's coming out, you're getting some sinus issues. These COVID symptoms will be very much like those things. So that's why testing is so important, so that you know if you're positive, and then you can do steps to prevent exposing someone who's at very high risk.
Any other questions for Dr. Riggs?
I have one more for Dr. Riggs. How often would you recommend someone be tested?
Yeah, we get that question quite a bit. So some of the research that we're seeing in workplaces, for instance, that are doing testing, it isn't so much about a frequency of testing as it is taking action once you find a positive. And, you know, the places we really are concerned about testing and doing it on a frequent basis, and CDC is actually putting out some guidance specifically related to long-term care facilities. So I think it's going to be more of an issue in places where there are confined people, whether it is in the jails, prisons, or long-term care, or any congregate housing. They're going to come out with some more specific guidance about how frequently they should check their staff. There are less costly measures that they can do. Monitor symptoms, not just wait for tests, but monitor symptoms, you know, do that temperature check, you know, ask your staff to go home if they're showing any symptoms at all, and really doing things to mitigate in that way. But I think we'll see more guidance come out on that. I know I can use an example like for schools. New York City has a goal of, I think, doing 100,000 tests a day, which is a huge amount. They want to test all their staff at their schools every other week so that they can pick up quickly if someone is positive and send them home. And of course, they're doing all the other screening measures as well. Again, these are just things that some are trying and what they think might work for their community. I think their effort of testing the staff, they're not testing the kids, and they want to pick up a positive as quickly as they can and get that person home and reduce the risk of spread. Doing things like cohorting, keeping the same like shift workers together all the time. Don't let them mix shifts. And, you know, if they're working in one section of the business, don't let them work in the other section of the business. At schools, we're doing that where we, you know, some jurisdictions are going to have kids only come Monday, Wednesday, Friday, and some Tuesday, Thursday. That's an attempt to give a little space on the buses and in the hallways. And, you know, steps like that are some mitigation measures that we can do to help prevent. And more guidance, I think, will come out on like how frequently to test, what would be recommended. You know, I think it's hard for CDC to say something that would fit all the states. That's why knowing what's going on in your jurisdiction is ideal. If testing is available, which it is in Kentucky, and it is available in Eastern Kentucky, we can test frequently. You know, places like Arizona, even on the island, I was just on a call with the Virgin Islands. They're having shortages of their reagents. They're having shortages of the pipette tips, the plasticware you need to do the test, because they're so remote, it's hard to get things to them. And other jurisdictions didn't arrange those deals like what we saw in Kentucky with labs locally that could ramp up testing a lot. So I think we have to kind of get a sense of how available is the test. Do we have enough reagents? Are there other things that you can't put in place that would necessitate testing being a more appropriate way to do it? But I think anybody working in high risk, anybody out in the public, like if you know, for instance, like I know preachers or the priests, they were getting tested a little more because they're interacting with public all the time, or they're there, you know, even though funerals were limited, they're there at funerals, they're there at bedside of those who are ill. They're out there once again doing that. So it makes sense for somebody who's in that higher risk, whether it's a school, health care, or somehow in the public or interacting closely with people, that they should get tested more frequently.
Thank you.
Sure.
All right. Well, Dr. Riggs, I really want to say thank you for sharing your expertise and sharing these resources with us from the CDC webpage. We'll be happy to share the links to these pages with our constant contact for our general membership with the chamber. And we've recorded this today, so we'll likely try to share that with folks as well who may have missed it. But I do want to once again say thank you for taking time to sit down with us and walk us through some of our questions and concerns. We really appreciate your fitting us in your schedule.
Sure, happy to help.
All right, and it's just about 1 o'clock, so we'll go ahead and call an end to the meeting here. Thank you all for joining us, and be on the lookout for next month. We might try to do a similar kind of format with a virtual meeting, so if you would like to attend with us again, we'll try to do that. So thank you all again for joining, and have a great day.
Thank you.
Bye-bye.
Bye-bye.